Welcome everybody to case management and improving adherence. So first of all, I don't know if this has been done with other classes you guys have taken, but I really hate looking at black screens. Can you please turn on your camera if at all possible? This class is really meant to be interactive. You get a lot more out of it if you ask questions and speak up. So if you could please raise your Zoom hand, unmute your phone, make comments. I would really appreciate it. And you guys will get a lot more out of it. So first of all, what we're going to be talking about is identifying and treating people who have TB disease, finding and assessing persons who've been in contact with TB to determine whether they have latent infection or TB disease, and providing them with appropriate treatment, using targeted testing strategies to identify and treat persons with LTBI at risk for developing TB disease, and identifying settings in which there's a high risk for transmission of MTB and applying effective infection control measures. So that's what we're trying to do with TB. And the way we do that is with case management. Case management, which as nurses, you've probably done some prior to this, but is an efficient coordination of healthcare services to achieve specific and measurable outcomes, providing patient-centered care for completion of treatment, and to ensure that all public health activities relating to stopping TB transmission are completed. I know I'm reading the slides, but this is really important to get. Case management. TB is one of those areas of nursing that uses case management a lot. This, if you haven't seen it, which if you've been working in TB for more than 2 weeks, you probably have at this point. This is sort of the Bible for TB treatment. It changes, and it's changing as we go, as we learn new things. But this is a really important document to take a look at. One of the things it brings up is case management in TB care. One of the nice things about TB is all these guidelines have nurses involved in writing them as well. So when we talk about case management, who's responsible for that? The case manager, together with the patient, develops a case management plan. We want to really look at needs and barriers that interfere with treatment adherence, because we really need to finish TB treatment. You can't just start it. You need to finish it as well. Otherwise, you cause more problems than good. Key considerations when developing a plan are educating the patient. Sorry, let me go back. One person is assigned primary responsibility for case management. There's a whole team that works together, and the team may vary depending on the needs of the patient. You can have nurses, outreach workers, physicians, social workers, health departments, other health departments, and that varies depending on the patient. Unlike other diseases, TB treatment and successful TB treatment is primarily the responsibility of the case management team. It's not the responsibility of the patient. And that's really different than treating somebody's diabetes or their hypertension or something like that. In TB, it's up to us to get that treatment finished. It's not as much up to the patient, but we want to include the patient, obviously. So in a case management plan, the case manager and the patient develop that case management plan together. It's individualized to the patient and should always be culturally and linguistically appropriate to the patient. You want to improve treatment literacy by educating the patient about TB, including transmission, treatment, possible adverse effects, and length of treatment. Discussing expected outcomes for treatment, specifically the ability to cure the patient of the disease. A lot of people think that TB is not curable. And we really need to help people learn that, yes, it is, but you have to take your treatment. We can look at the need for incentives and or enablers to promote adherence to directly observed therapy, to following up tests and follow-up tests, and to appointments. And then look at review methods of adherence support and plans for assessing response to therapy, including follow-up testing that will occur during treatment. and discussing infectiousness and infection control measures. Um, it's very important for nurse case manager or the primary case manager to know any other health issues and should know the current medication list for non-TB medications. There can be a lot of interactions with other drugs that may be addressed with the primary care or specialty physicians. So, for example, recently we've had a patient in Washington that we've had to help the local nurses work with the primary care physician because the person was on Coumadin, and there can be a lot of interactions with rifampin. We've also had some people who are working with methadone clinics, and we need to adjust the doses of their rifampin to work with that, with the methadone. So there's a lot of coordination with other programs when you're doing patient-centered care. It's really important to establish rapport with a patient at the start of the initial visit. The relationship with the patient will develop over time. However, the foundation from which a trusting relationship is established begins immediately. And there are many ways to develop rapport using effective communication skills, finding common ground, displaying respect and empathy. I actually heard a talk yesterday that one of the nurses was saying the way she works a lot with patients is, and to establish rapport, is asking what they like to cook and getting some ideas of, getting more of a personal relationship going along the same time. Unlike the hospital or other nursing jobs, you have lots of time to develop rapport. You want to start right away, but you're going to have daily visits for directly observed therapy for 6 to 9 months or longer. You're going to get to know that patient pretty darn well, which is one of the lovely things about TB, is that you actually get to know your patients. You really want to think about effective communication skills. Active listening is a technique, and you all probably know this, but of careful listening and observation of nonverbal cues with feedback in the form of accurate paraphrasing. It requires you to pay attention, understand, respond, and remember what is being said in the context of intonation, timing, and nonverbal cues or body language. Validating by acknowledging the concerns of the patient. If somebody isn't really, you want to make sure that you really understand where they're having fears about something. And oftentimes there's a lot of stigma around TB, and that will come through in the fact that they don't want to talk about things. They don't want to tell you information about other people. So you really want to acknowledge those things up front. It'll help you a lot in the long run. And culturally and linguistically appropriate communication. So speak to the person's level of understanding. So, and with that, I mean, it could be language. If you're talking to a patient who doesn't speak English or any language that you speak, it could be culturally. If you're talking to somebody who is, I've worked with patients who are unhoused, and if you go in talking about working, keeping their meds near the refrigerator and on the sink, and they can't do that. But you can also have patients who are really well off, and speaking to them in a manner that they understand as well is equally important. So if you could do me a favor and unmute your camera, your phone, your computer, and give me an example of communicating at the patient's level of understanding, both culturally and linguistically. I gave you a couple, but let's hear some from you guys that you've used. You all have been nurses at least for a little while, maybe not in TB, but if you could unmute and throw out an example, that would be great. I can't see the chat, so if there's something written there, if Shweta, you can read those to me, that would be great. I know there's a couple comments in there, I think, but
That was just me, Carolyn, telling
Oh,
people to
okay.
use the raise their hand option to be called out.
Got it. But you guys better speak up or I'm going to start calling on you.
You can use non-medical language.
Perfect. So that's a great one. It's amazing how often we fall into using clinic speak and patients have no clue what you're talking about. Heck, my friends don't have a clue what I'm talking about when we talk about things sometimes. Anybody else?
You can use language line assistance.
Okay, that's a great one, and we'll talk about that in a minute as well. That's definitely important when you're thinking about other languages, but also interpreting wording with language line, and we can talk about that too. Sometimes they can, if you're not completely fluent, I speak Spanish, but there's some words that just don't translate for me very well, and having somebody to help me, reword something is useful. Anybody else? Okay, so effective communication and education techniques. Again, you want to talk at an appropriate language level, use simple and non-medical terms, discuss the most important topics first, and repeat them again at the end. Repeat important information. Did I just say that? I meant it. Listen to feedback and questions and use really concrete examples. Make interactions with the patients as positive as possible. One thing that's really important when you talk to patients, praise them a lot. This was something else I heard yesterday that was really interesting to me because it's not something that I do regularly because it seems like giving a medal for everybody on the team instead of just the person that won. But and I know that's kind of a weird example, but anyway, giving positive feedback about, you did a great job finishing all those pills yesterday. That's a hard thing to do when there's so many of them. Or I'm so glad you were able to take your kid into an appointment at the pediatrician's yesterday. I know that's been really tough for you. So that was a great job. Anything that's positive. Provide patient education materials if you can get things, which I know sometimes is hard in different languages, but provide the paper materials or online materials for people to access to follow up on things that you've talked about so that they can go back and look at things later. I have one example of that, of a patient I was talking to about LTBI. She didn't want to take it. She was pregnant. She said no, and she'd been a contact to active TB. Or no, she wasn't pregnant. She wanted to get pregnant. And so I left the information there, and she called me like 3 weeks later and said, every time I cough, I get scared. I want to take the medicine now. So it's always a good idea to leave it there just as a kind of reminder for people. And then limit the amount of information at any one time. You're going to be seeing this person a lot. Not to say you don't want to give the most important stuff, but we can't take information all at once. This is a lot of stuff to share. So give it in small bite-sized pieces. You really want to teach back things, so ask them to paraphrase what you said to ensure understanding. Don't ask, did you understand me? Again, from yesterday, one of the things this person who was teaching said, and this is they were talking about a particular cultural group, but she said, if you ask people, did you understand me? They're going to say yes, because they want to make you feel like you've done a good job teaching. If you, nobody's going to say, I don't get it. It's like, you screwed up. You didn't teach it right. So make sure that you ask them to paraphrase what you said. And then again, with different cultures, be conscious and respectful that some cultures only allow, for example, the male to speak and ask questions. But you do want to at least give them a chance to look at each other and talk about it. So think about who you're talking to too. Really important to use open-ended questions. What do you know about TB? What causes TB? How do your family and friends feel about it? Don't give people the option of saying yes or no and nothing else. When you're educating the patient about TB, it should begin at the initial visit and continue with every encounter from day one to the last day of the 9th month. Information about TB transmission and pathogenesis, and everybody can get at least some understanding of that. Even, again, don't use medical speak for it. Expected outcomes of treatment, the benefits and adverse effects of the treatment regimen, that you're going to be doing directly observed therapy, and how you do that. Assessment of treatment response, what kinds of follow-up testing do we need to do? And you want to talk a lot about infectiousness and infection control, because you're going to be doing contact tracing and people need to know what to expect and what to tell their friends and family about what you're going to be doing. One thing when you're talking to patients about the length of treatment, don't tell them, oh, it's going to be 6 months. Because when 6 months comes, they say, okay, we're done. It's like, no, it's going to be 9 months. And when 9 months comes, it's like, no, it's going to be 12 months, because things change along the way. So people need to know it's a minimum of 6 months. It's not, not a definitive or a definitive date. And we'll talk about the length of time and how that plays into this. So again, what's the most challenging aspect of case management in your past few months? All of you have been working at least 3 or 4 or 5 months, a year in TB. If you can unmute again and tell us about a situation you've encountered.
Are you talking either active or LTBI? Either one?
Either one, anything.
All right. So I have a client who's had trouble with 3-HP, and now they're having trouble with INH. So the question is going to be whether they're even going to be able to continue with their treatment.
Okay. And how are you dealing with that?
Well, I mean, the side effects that they're talking about are really just coming out at the last minute. The client mentioned she's been having the pain, but failed to tell us.
Okay.
So we're going to have to do some more education. We've got to do some labs. We're going to have to make some decisions on how we're going to proceed with her treatment.
Okay. And how far along is she in treatment?
Well, she's been maybe 2 months.
Okay. Of a 9-month regimen of INH or of
So no, this is an LTBI client, so it's a 6 months
of INH.
Mm-hmm.
Okay. So an alternate regimen. We usually use 9. I know that we're, it's acceptable, but usually it's 9. But regardless, and so yeah, there's a lot of issues then to bring up with patients about how to deal with this. What might be something you'd bring up with a patient about? How would you explain this to them, or try and explain what you're doing or why things are changing, or to keep them engaged?
The complication with this particular client is that we've had to change one regimen for another.
Mm-hmm.
So their liver enzymes have been relatively high on the first treatment. So that's why we're moving to this treatment. They understand when they're having these kinds of symptoms that we may have to do some more liver enzyme tests. But probably the most important thing was what I needed to know, that she was having difficulty early on. So what happened is she restarted her INH. So she's only been on it now for an additional 10 days, 12 days. So it's going to be difficult trying to see how to move forward.
Right.
Since she had problems with rifampin, now she's having problems with INH. I mean, I'm not sure what options we're going to have. We may have to talk to her about trying to. I mean, she's so sensitive to the medication, so it's going to be a lot of education. If we can't proceed with the treatment, then it's going to come down to education. I don't want her to progress. So I'm personally not sure how we're going to handle this.
Right. And is your physician involved in all the education as well, or is it just you?
No, it's myself and there's a nurse practitioner and there's a team of us.
Okay, okay. And that's always helpful. Again, to have a team to be able to play off of each other a little bit and reinforce what one or the other is saying. Anybody else have a challenging aspect that they've had to deal with?
I think one of the things, this is Anna. One of the things too is maybe involving the team of providers that don't deal with the TB, because a lot of times patients have other comorbidities, and when it's an active TB case, we're looking at the TB and we don't want to tell the patient, well, we only care about your TB, because that really dismisses the fact that they're a whole person with other problems. So that's been helpful. And even referring our patient to a specialist who can address their other issues, because it's all part of the TB. And then we also had a patient that was on latent TB treatment. And in her culture, women were very dismissed. The husband wouldn't let us talk to the wife for the med start. She came in, he said they had to leave, they couldn't stay. And he rushed out the door with a bottle of pills without much of any explanation. We did notice that she had a large cut, like a gash in her arm. And it really made me worry about her having maybe some domestic violence. So what we did was we were calling her on the phone and to explain this stuff. And then we eventually had our outreach workers go to the home to do weekly DOT, because she was just on 3-HP, to lay eyes on her and just make sure that she was okay and that she was taking her medicine, because the husband just refused to let us talk to her.
That's
And she
perfect.
didn't have a phone. She didn't have a phone. The only phone that they had was the husband's. She was at home with a bunch of children and no telephone. So we had to go to the house.
Yeah. So those sound like perfect examples of case management. One is bringing in other people and other programs. We don't work in a vacuum. I know a lot of programs actually draw the A1Cs and then refer people out and make sure or share those with whoever's doing the diabetic care. That's what case management is looking at that whole picture and then using your other resources, using the fact that we can do DOT. Your diabetes provider can't do DOT and go check in on somebody to make sure that they're okay. And, you can't, you don't really want to call social services with some, right off the bat and say, we think this woman's being abused. So using that to lay eyes on someone, that's a great example. So interpreters, we talked about this a little bit. It's really best to use trained medical interpreters whenever possible. If family members have to be used to interpret, this should not include kids. And again, you want to be really careful with the family members, because just like Anna said, you might have a family member who doesn't understand, really doesn't want the person to be there anyway, and so they're not giving correct information. So using trained medical interpreters is really important. And pretty much anywhere on the mainland now, you should be able to get, and even other places, you should be able to get mainland, only because I'm worked in the islands. And so I realize that sometimes getting a hold of online translation or a telephone translation is difficult. But you really want to use language line or something if you can. So question for you guys. How often do you use a professional interpreter? I think this is a polling question.
All the time.
All the time.
All the time, yeah.
Instantly. Frequently.
Did the question pop up?
Yes.
Mm-hmm.
Yeah, it did.
Okay. So mine says 0, 1 answered. I don't know if other people are, maybe this is me.
Okay, I have about 66 people who've participated, so I'm going to end the poll in a few seconds. Okay, I'm ending it right now.
Okay, so about 60% use them frequently. So just a quick question for those of you that rarely use one, and I don't know how many people that is. Why is that? Do you not have access to it? Or do you not have people that speak other languages? If you want to just unmute and make a comment, that'd be great.
We don't often have people who speak other languages.
Okay. Does everybody have access to it? I know we have a few counties in Washington that don't have access, and we don't, I mean, the state's actually looking at trying to find a way to make sure that they do. Language lines are a really good resource for any health department. You know, one of the things that I did when I did home visits, I would have language line on my phone, and, you know, it was on speed dial. So I would call people a lot from the family's home just to be able to talk, you know, about side effects or anything else as we're doing the visit. One thing that did come up with in using a language line for me one time was a language that was not very common, and my people the patients that I was working with actually knew a lot of the interpreters and didn't want to talk to them, which usually you can get away with. You know, there's enough interpreters from other places that it's not an issue. But with this really small community, there was a lot of the same stigma as there is when you use somebody that's local. But not very often. So in terms of guidelines for the interpreters, medically certified interpreters is ideal, but it's not always possible. If you're using somebody in the room, stand next to or slightly behind them to promote eye contact with the patient. Look at the patient, not the interpreter, while you're having a conversation with the patient. That was something that was always really hard for me. But I'm getting better at it. It's just one of those things that you're used to talking to the person who's actually talking, that you're actually talking to. And so sometimes that can get a little bit awkward for me, but it's much better for the patient if you look at them, not the interpreter. If you can, meet with the interpreter beforehand to discuss the goals of the encounter, provide instructions and guidance, and make sure the interpreter is comfortable with the questions and topics that will be discussed. That's the best. And then just remember when you're talking to interpreters, they're not repeating exactly what you're saying. They're interpreting what you're saying. So sometimes those responses or whatever can be really long, or the patient can talk for a long time and then the interpreter turns around and says 3 words to you. So don't get weirded out by that. If the patient doesn't understand a concept or word, the interpreter should tell you and not try to explain it to the patient. I've actually had to correct patient interpreters when I've realized that they were doing that, because sometimes they don't understand exactly what they're talking about, and it's helpful to make sure that they really understand the concept and aren't interpreting something incorrectly. So again, asking them to explain questions or answers to you that aren't clear. Keep the messages simple and factual, use short phrases, and focus on one topic at a time. Again, I like to talk too fast, and sometimes I forgot or would forget and, you know, go off on a tangent, and people can't, like I'm doing right now, and people can't keep up when they're trying to interpret. Okay, so let's talk a little bit about adherence to treatment. It means following the recommended course of treatment by taking all medications as prescribed for the recommended time frame. Non-adherence is a patient's inability or refusal to take the drugs as prescribed, or missing appointments, that kind of thing. So taking medications inconsistently, missing clinic appointments or follow-up tests, missing DOT appointments, or just plain out refusing medications. Really important to explain the importance of adherence. that it's going to make them feel better sooner. And one of the problems with that is that oftentimes TB is caught early, which is nice, but people don't feel that sick, so they don't understand why they're taking this stuff. And, so helping them feel better, they already feel better. So sometimes that's an issue, and bringing that around is important to make them understand, whether it be showing them their x-ray or whatever it is that made you decide that this was actually TB. Explaining the importance again, a lot of times people don't understand that TB is curable. A lot of culture or people from endemic countries, it's not, because they don't have the treatments available, or a lot of places where HIV is also endemic, the two diseases are so linked together, and there may not be treatment for the HIV, and so people die of TB because they're not able to control the HIV or get medications for the TB or both. Explaining the importance, again, helping them return to their normal activities and preventing the further spread of TB to others. And you really want to focus on things that are important to that patient. So in that developing rapport, you're figuring out what's important to that patient. Man, you have 5 kids, and I know you really love these kids and are really, and they're really important to you. We want to prevent this spreading to them. So you need to take your treatment to prevent that from happening, or whatever the issue is, whatever the topic is that's important to them. You want to see your grandkids. We really want to get you back to being able to do that. There's different ways to document adherence with DOT or electronic or video DOT. Sometimes those tools have ways to document in the program. Counting doses is definitely important when you chart those. We're not going to go into too much on adherence tools and programs. That's a whole nother talk, which we've separated into a whole nother talk because there's so much information. But because each area uses their own adherence tools, there's a lot available. They can be modified to individual patients and their needs. One thing I did want to bring up is, and you probably know this at this point, but treatment weeks are not calendar weeks. You calculate treatment based on the treatment weeks to determine if the treatment is complete. So it's the total number of doses taken equals the total treatment weeks over the frequency of administration. So if you're giving somebody 26 weeks of treatment, and it's 5 times a week, or it's 7 times a week, or it's 2 times a week, the total number of doses is different. So for example, 6 months of treatment is not 24 weeks, it's 26 weeks, because you're dividing 52 weeks in the year by 2. So there's a lot of weird little things that go into treatment completion, and which is why we take a whole nother course to talk about that. But it's important to keep track of how many doses and what the regimens are and the frequency of that. DOT versus self-administered treatment. DOT is the standard of TB treatment and has been for years, and it's worldwide. It's the standard for treatment. It allows, and DOT is not just being a policeman and watching somebody take their medications and make sure they swallow them. It's really recommended to all patients start off on DOT. DOT has 3 purposes. Ensure they're taking and tolerating the correct dose of medication. These regimens can be complicated at first, especially if they've been hospitalized. They're complicated for me, and I've been doing this for a really long time. I can't even imagine patients sometimes trying to figure out which doses they need to take when, and then you're telling me to take 15 pills at one time. Are you freaking crazy? So it's really important that they get the right doses and that they're tolerating it. We want to ensure the patient's not having any adverse reactions that need to be reported to the provider, and telling people that we can pick up on those if we watch them take their pills every day, so that they don't feel like you're just being a policeman at the house. And education occurs throughout the course of treatment. So if drug resistance is detected and there's changes in the regimen, we also need to really follow up on that on a regular basis. Being there for DOT every day is for questions, for patients that are for the patients, for family members. It's also a good way to look at who else is living in the house so that you can pick up on other contacts. There's a lot of things that happen in a DOT visit, much more than just, again, I've said this how many times? You're not being a policeman. You're trying to manage their care in the best way possible. So DOT can be supervised by a variety of people. What it shouldn't be is the parents, the friends, the family members. It really should be somebody medical from your health department, or a school nurse or a pharmacist or somebody that you can work with directly that can give that medication. In Connecticut, I believe they use the ambulance services that supervise DOT because they're out and about anyway. A lot of health departments, we have outreach workers or DOT workers. So it can be a lot of different people, but it needs to be somebody that isn't so invested with the patient that they can be swayed by the patient too. I'm not really going to take these. So DOT, all patients with pulmonary TB should take use directly observed therapy. We really encourage extrapulmonary TB patients to also have DOT because they can also develop drug resistance. They may not be contagious at the time that they start treatment, but if they're not taking treatment appropriately, they may end up with problems later. Even patients who intend to take their medicine might have trouble remembering to take their pills every time, especially once they start to feel better. I don't know how many of you have been given, 10 days of antibiotics, 2 weeks of antibiotics, and after 12 days, it's like, I'm done with this. And we're people who know better. So I explain to patients that DOT is standard of care for everybody, just like seeing a specialist for TB. And, and I'll explain my own personal experiences on forgetting to take medications. I also had, for one example, I had a patient she was a doctor's wife, and actually an infectious disease doctor's wife, who we were doing DOT with. At first we thought about, anyway, she started having some nausea that we had to work our way through. At the end of treatment, she told us that if we had not come over to give her medicine every day, or that she would have stopped taking it. And this was a very well-educated infectious disease doctor's wife, who then said if we had had her husband give her DOT, they would be divorced by then. So it's really important to think about who you're using for DOT again, and to use it for everybody. Non-adherence to any long-term medication is can be common and can be problematic. Think about HIV. It's hard for people to remember that stuff. So we want to make sure that people are on their treatment, and that's why DOT really does work. High priority groups, anybody with drug-resistant TB, anybody with positive sputum smears, anybody who's had a delayed culture conversion or treatment failure or relapse in the past, HIV, anybody that's at high risk for non-adherence, somebody who's homeless or in unstable housing. It's just hard to take sometimes because, medications get lost, whatever. Alcohol and other drugs can be an issue just because you forget. Correctional care or long-term care facilities, if you can get staff to help you with that, that's much better than patients taking it on their own. And anybody that's been previously treated. If we're having a repeat TB disease, something's going on or went on before. For latent TB, Wayne, did you have your patient on DOT when you were doing 3HP? But it can be considered for patients who are at high risk for TB disease, young kids, HIV, other immune suppressed, non-adherent to LTBI in the past. Wayne, I believe it was you.
Sorry, I have a situation that has occurred with that same
Oh.
client, so I have to address it. Sorry.
Okay, no problem.
Yeah.
So why are some patients non-adherent? I believe you get a polling question here. Select any that apply. We have some answers.
Yeah, I'm just waiting for a few more people to complete, and then I can share the results. Okay, I'm going to end the poll.
Okay, so looks like everybody thinks at least one of the, some of these are reasons for non-adherence. And it's all of them. For a variety of reasons, people can be non-adherent to treatment. They might be feeling better. They don't want to keep taking it. They don't really understand why they're taking this stuff. There may be cultural beliefs. It's Ramadan and I can't eat during the day. It's Yom Kippur and I can't eat today. Whatever it is. There's language barriers. So again, people may not understand. They can't get into the clinic because it's not open when they're off work. Not having a good relationship with the healthcare workers. So again, that's why starting at the beginning with developing a rapport with the patient is really important. And if whoever's going to the house to do a DOT finds that they're really not meshing with this person, if you have any chance at all to switch people, sometimes that's useful too. If you've got more than one DOT worker, or more, maybe trade off or something to try and maintain a relationship. There might be other priorities. I really don't have time. I've got a job. I've got to pick up the kids. I've got whatever it is. There's too many things going on. I can't make it into the clinic because I'm working. Stigma is a huge reason. People don't want other people to know that they have TB. So they don't want their pills around. They don't want you, giving them to them. And then mental health issues. So have you dealt with a non-adherent patient in your clinical site? And if you could just unmute and say what happened, that would be lovely. Anybody?
I have an example.
Great.
This is Christine Conner. I'm with the Vermont Department of Health.
Hi, Christine.
So, hi. So we had a person that had difficulty adhering. They have been adherent overall, but we've had a few stumbling blocks along the way. Nothing that really put them at risk for having to restart over or lengthen their treatment, thankfully. But a lot of everything that was on that poll basically applied to this person. One thing is, there's not always a lot of funding or support for incentives to incentivize people to continue to take medication. So with this person, they were self-employed. And so having to isolate was a huge burden because then that completely stopped their income. They were a taxi driver, so they only made as much as they made during their working hours. So being in isolation cut off all of that income. And so, and they didn't qualify for a lot of social services because prior to having isolation, they were making a salary that put them above the qualifications for a lot of assistance. So they owned a house, they couldn't get housing assistance. They had a good salary, so they didn't qualify for assistance with electrical bill assistance or other service assistance. So we had to be very creative in how we can support that person so that they could have food during their time in isolation, which was extended based on their comorbidities, and being able to pay their HOA fees and their mortgage, and a lot of that included negotiating with their financial institutions so that their financial institutions understood that this was like a temporary pause in the ability to pay. Beyond the financial burdens, there was, the cultural barriers. So, our staff are mainly female, so they were more apt to listen to the male physician as opposed to the female nurses that were coming in providing DOT. So we had to coordinate with the physician to make sure that what we were providing as public health recommendations and guidance on DOT was backed up by the provider, which of course they were, but just to make sure that there wasn't any, what's the word for it? Is it triangulation, where they pit providers against each other? And it wasn't an intentional thing. It was just, the not really understanding what was going on and feeling as though the person who's coming to their house was not the expert, but the physician was. So nothing, sometimes, they would decline taking their medication until they could validate it with the physician. They had diabetes, so the diabetes was affected by the infection. And so having to, co-manage everything made that also a barrier. And of course, there just was, once they started feeling better, there was that pushback of, why am I taking this medication when I'm feeling better, but the lab work is showing that I'm having harm to my liver. So if my liver enzymes are going up, I'm not going to take this medication anymore. So there was a lot of re-education, reinforcement, and reassurance, but also validation for them of, we understand your concerns, but let us help you support.
Kristen, do you want to teach this part of the class? Because that was a perfect example of
No, thank you.
So that was perfect example of how you get around a lot of this stuff and what kinds of things cause people to be non-adherent. It's not because they don't care. It's because of all of the things you just mentioned. And one of the things that you really showed is TB treatment and TB work is a team sport. You can't do it by yourself. I'm female, my physician happens to be male, or, I speak English and Spanish, but my DIS worker speaks Marshallese. We need each other. We need all to work together. And so this was a great example. It also is a great example of how nurses do a little bit of everything. We become social workers, we become, financial counselors, we do all kinds of stuff. So, looking at barriers to adherence, there's several additional strategies healthcare workers can use to address those barriers. Contracts. with the patient. So I actually live in Colorado and I worked in Denver for a long time. We had a mandatory letter that patients needed to sign saying they would cooperate with TB program and take their medications and follow up on appointments and what the consequences were if they didn't do so. Everybody had to sign that. It was not, oh, you look like you might not, you're going to become adherent, so you sign it. Everybody got it. Even my patient who was an ID doctor's wife had to sign it. Washington has something similar that all the local health jurisdictions use, but having that up front sets the ground rules. And then helping patients keep appointments. So reminder calls, whatever, text messages. People are using Facebook a lot now to send reminders. Anything you can do to help patients remember. A lot of cultures, especially in the Marshallese patients that we worked with and the Micronesian patients, they don't really use calendars, and time is not a big deal for them. That's not the way they work. So when they've come here and have to fit into a time slot for an appointment that is between two other patients, and it's pretty minimal, it's like set, you got to do that. You really have to explain to people why that's important. And so helping and educating patients on what's important about that. You mentioned incentives and enablers, and we can talk about that in a minute. And encouraging patients to seek support outside. So encouraging them to go to the bank to talk about figuring out their mortgage, or working with a social worker or whatever. Giving TB drugs in easy to take preparations. So yes, we used to give, crush all the pills and put them in liquid for our kids. But I've had some 40-year-old patients that could not swallow a pill. And so they ended up getting the same liquid preparations because that's what they could swallow. And again, coordinating with other services. A couple of you have brought up, working with the diabetes providers, or the rheumatologist, or whoever it is, and helping to coordinate those appointments as well. So making sure that they can actually get to those appointments, because that diabetes needs to be taken care of, or the TB is not going to get any better either. So really helping, even if it's sending reminders for your diabetes appointment, is also helpful. So these are a couple of letters, I don't know, that we use in Washington, or that the local jurisdictions use, that patients sign at the beginning of treatment. If your TB program doesn't have something similar, you can always borrow and adapt. So feel free to call. We're happy to send the Washington ones. I know Colorado had some as well. You can always borrow and adapt. I'm sure other states do too. So that's the other thing with just the borrow and adapt. Nobody in TB wants to reinvent the wheel, so we all borrow from each other. Don't feel shy about calling to say, hey, I saw this talk that you did a while back and it was really useful, and so can I borrow that? Can I have that form? By all means. Everybody is happy to share. So we talked a little bit about incentives and enablers. Incentives are small rewards that are given to the patients to encourage them to either take their own medicine or keep their DOT appointments. And incentives should be chosen according to the patient's special needs and interests. Enablers are things that make it possible or easier for the patient to receive treatment by overcoming barriers such as a lack of transportation. For example, giving somebody bus tokens or bus fare or taxi fare. We give grocery store gift cards a lot of times that include the gas. So, or, work at the gas station at the local, Kroger, King Supers, Walmart, whatever. So that will help pay for a tank of gas if people need it. So those are all enablers. And there are as many as you can possibly think of. I've used stickers for kids. We've used a calendar that the kids can put stickers on, and at the end of it, they get every day that they take their medicine, and at the end of it, they get a little gift card to go to Target and buy a toy. You know, you can be as creative as you can get with all kinds of things. You brought up helping, or Christine, I think you said you couldn't afford to help pay for rent or whatever, but you know, every health department's a little bit different. I have to say that when I was working in Denver, we couldn't afford to pay for a lot of stuff. So we started doing, I became a race director. We did a 5K race to raise funds, the Stop TB Trot. And so, you know, you can come up with all sorts of things to get money. We used to go big for gift cards, and the stores will give them to you if your health department really has no funds to provide for things. Any other examples of in creative incentives or enablers? I'm gonna unmute and just throw it out there real quick. Okay, let's go on to a little polling question. Can you take someone to court for non-adherence? Do we have the polling question for that?
Hi, I'm sorry, I'm having issues with that one. Give me a few seconds.
Anybody have some incentives and enablers while we're waiting?
I think Ajwa Sam mentioned in the comment phones, data cards to help keep client in contact with case manager was one of
Those
the
are
incentives.
great. Those are great. We've given away in Colorado, the state has a handful of phones that they will let people use. They have to sign away their firstborn child before they get the phone, but in order to get it back. But but we've used those. That's a great idea. The calling cards is also another one. People like to be able to call overseas if they're away from home. And so giving people that option is always helpful. Looks like some of you say yes to going to court, and a few people say no, you can't. And yes, you can. There are legal remedies for non-adherence. If you in Colorado, it's in the state statute that if someone is contagious, you can take them to court. But we had to make sure we gave the patient a TB agreement at the beginning to sign that detailed this. So when I said we had letters to, you know, agree to take treatment and agree to take DOT and all that, those had to be signed ahead of time. And they said you could be taken to court if you were still considered contagious and you're not complying, so that people are fully aware of what they're getting themselves into. Washington, for example, where I work now, it's a bit more difficult because they don't have that in their state statute. But if you can convince a judge, then it is possible. So it's really is something that you can do. But progressive intervention plan is is important. You need to begin with determining the possible reasons for non-adherence. So all those things we talked about earlier, and I'm trying to identify those problems and ways to combat them, such as using DOT or incentives, enablers. You have to have that adherence agreement signed up front, because they need to know verbally and in writing of the importance of adhering to treatment and the consequences of failing to do so, and that legal actions could be taken if they refuse to take their medication or they refuse to show up. And the biggest thing, document, document, document. No judge will even look at you twice unless you have that all documented completely and really clearly, that what you gave the patient, the dates when you did it. And so in Colorado, which is where I work primarily as a case manager, we had to document everything from the day that first document was signed to the missed doses and when, to what you did after that missed dose or missed appointment. And so documentation is vital. Court can be used as a last resort. I have gone to court once. It was not fun, but it's definitely possible. So we really want to use progressive measures if possible, and use that as a last resort, because it will screw up your relationship, or oftentimes will. So you want to use it as, again, as a last resort. Try and everything else you can beforehand. So what are some strategies that have been successful, or what have you, some lessons learned so far when managing patients for you guys? Anybody want to bring some things up? What are some successful strategies you've had? Is there anything in the chat, Shweta? I can't see it.
No, there's nothing in the chat.
Okay, so again, just as to reiterate, TB case management is patient-centered. You're really thinking about the patient and including the patient in developing your treatment plan and following up as you go along with them. But because that can really help in your success in having successful outcomes. Being culturally and linguistically appropriate in your education, assessing barriers at the start and ongoing during the whole course of treatment. DOT and video or electronic DOT can be really helpful. You want to start with in person, make sure that the patients are doing okay with their medicines and not having problems, but using video or electronic DOT really helps to keep patients, they can get back to their real life and take the medications when it's convenient for them, or at least more convenient for them. Really depends on what you have in the way of programs that you can use. So some are asynchronous, some are synchronous, meaning in Denver, we had asynchronous, which meant the patient could take it whenever they wanted, and they sent in a video clip that we then reviewed. So they could take it at 11 o'clock at night before they went to bed if they want. Other places may have it where you have to take it during office hours, but it can be morning, afternoon, whatever you want. And then, it may be it's in person, so you're watching them take it and talking to them as they're taking their medications. And providing incentives and enablers, and they don't have to be expensive. A lot of the stickers that I gave to kids came free in the mail to me from Nature Conservancy, because they were little animals. Whatever it is. They don't have to be big things. Yes, paying rent might be, but there are ways to get around and find ways to fund that sort of thing if possible. And improving adherence really begins at the initial meeting. So the very first time that you see them, you're explaining what's going on and educating that patient on what to expect and why, and getting that rapport going so that they trust you. Anything else? I'm at the end of my slides, so we need to learn from each other. That's the best way that I've always learned. And when I listen to webinars, hearing other people's comments, it gives me a lot of ideas. And obviously, because the one I listened to yesterday, I was getting all kinds of ideas. So unmute your phone and speak up. Any questions, comments?
I don't have any, I don't see any comments in the chat either. I did leave the evaluation for this session,
Okay.
so I'm happy to hold back for a couple of minutes if people have any questions. Okay, I'd like to thank everybody for joining our session today, and thank you, Carolyn, for a great interactive session.
Thank you all.
Appreciate it. Thank you all, and we all hope you have a great weekend.
Have a good one. Thank you so much.
Thank you. Bye.